Hi, welcome. My name is Wissam. Today we're talking about everyday wellness. What is everyday wellness? Everyday wellness isn't one question. It's nature and movement, medications and product safety, plastics and the environment, emergency and preparedness, nutrition, mood, and the communities we lean on, often with information that's hard to find, hard to afford, or locked behind one language. Tools that use artificial intelligence can make that support easier to reach, but here's the harder question. When AI helps us day after day, what else are we trading? Energy, privacy, trust, or skills we stop practicing? Today, I'm walking through a wellness app, Scan and Find It, and a separate forecasting impact study on the research page. Useful for stress testing assumptions, not a report card on every feature. Scan and Find It is a general wellness and education app for phones, tablets, and the web. Think of it less like a doctor in your pocket and more like a careful guide to public wellness information, educational tools for nature and outdoor context, medications and product safety records, plastics and environmental awareness, fire and safety education, nutrition goals as one of several wellness paths, daily check-ins and a health timeline, optional wellness communities with friends, and an AI assistant you can ask in chat or voice, always with clear medical disclaimers. It pulls from public databases and trusted education sources, nutrition references, open FDA public records for educational drug and product safety context, recycling guidance where available, and health topic citations. So answers can point back to sources rather than inventing authority. Who does it help? People who need affordable access to everyday wellness information and support, people who want health communities and shared goals with friends, households that need experience in their language, and anyone who cares about general wellness, body, environment, safety, and connection, not only what's on a food package. They can also potentially support professionals who want fast educational reference in the field. For example, medical or care professionals looking up public label and safety education, not clinical decision support, electrical and other trade professionals reviewing safety and fire-related educational context, and wellness educators pointing people to sourced public information. It's also built with assistive technologies in mind, so screen readers can announce controls and content more clearly. None of those audiences or modules are proven by the synthetic cohort numbers we'll show next. Why existing solutions weren't enough for this build? Many apps silo one topic, food only, fitness only, or chat only, charge for basic education, skip multilingual and accessible design, or blur the line between education and clinical advice. This project is deliberately positioned as general wellness, not diagnosis, not prescribing, not a medical device, consistent with US FDA general wellness framing for low-risk wellness products. The FDA does not approve or endorse this app. Some product safeguards we have in place keeps under 18 accounts behind parental consent. We also have scan image safety checks. We check the photos before heavy vision AI processing, blocking any risky or malware-like payloads when enabled. We also have bot protection. None of these are perfect or universal across every deploy config. Treat them as defenses in depth, not proof of zero risk. Okay, before the study design, one idea matters. Forecasting. Forecasting means using historical data, current observations, and validated statistical or machine learning models to estimate likely future outcomes. It isn't unique to AI. Weather agencies observe the atmosphere, run models, and update forecasts as new data arrives. Economists publish projections for growth, unemployment, and inflation using official data systems. Public health teams model and forecast outbreak trends to support decisions. Climate science projects long-term change while explicitly communicating uncertainty. Different domains, same scientific workflow. Collect reliable data, prepare and validate it, build a model, test against past observations, and then generate the forecasts and refine as new evidence arrives. That's why this impact study borrows the idea of forecasting, not because it is as mature as weather or outbreak systems, but to estimate plausible scenario outcomes, surface risks, and guide improvements, while treating outputs as assumption-driven estimates that grow more uncertain as the horizon lengthens. The research page is educational systems modeling on a synthetic cohort. Same scientific discipline of stating assumptions and limits, not the same operational maturity. We partially budget for unknown error. Stated assumptions, scenario lenses, environmental cost sensitivity, disclaimers, and a hard call to validate with real data, rather than presenting a single tidy number as destiny. The biggest benefit side assumption, AI adherence lift, is still lightly stress tested compared with costs, and live equity or harm gaps aren't fully instrumented yet. So this work uses the structure of the scientific method: question, assumptions, method, results, limitations, next steps, not anecdotes. It is not a complete empirical trial with real-world data collection. The data here are synthetic profiles built from published summary statistics. For Scan and Find It, the question the research page is answering is narrow. Under explicit scenario assumptions, can modeled wellness proxy gains from AI coaching outweigh API hosting and planetary costs for a synthetic cohort without claiming causal proof in real users? Listen carefully. This is a forecasting simulation study on 1,000 informed synthetic adults, comparing with AI coaching versus without AI, barcode-only baseline lens, a study control, not a claim that the whole product is only barcode. At 90 days, 10 years, and a remaining lifetime horizon. It is educational system modeling, not a randomized human clinical trial, and it does not by itself prove cause and effect in real patients. So this is not some casual AI improves health, okay? These are assumptions to be validated. What is the scope? These runs do not score nature, fire, meds, education, plastic communities, multilingual equity, or professional workflows. They score nutrition, lifestyle, mood alignment proxies, and a population risk outlook model, and a USD benefit burden ledger. Science is iterative, progressively reducing uncertainty. Science doesn't fail when models change. Science progressively reduces uncertainty by observing, testing, revising, and replicating. Budgeting for known error doesn't mean science is useless. It means we expect residuals, revise models as evidence improves, and refuse false precision. Like researchers refining models for phenomena we don't fully understand yet, we treat this study as one contribution, not a final verdict. And we say out loud which uncertainties we've stress tested versus which we haven't. Recommended next steps, not current claims. The research UI itself says it. Validate with real longitudinal data before drawing casual conclusions. Then rerun as models and devices change, and where ethics allow, stronger field studies. Progress isn't always a straight line. We treat regression risk as an evaluation criterion. AI systems can drift or degrade. Over-reliance might weaken skills if tools replace practice rather than support it. And an active research concern, not a settled law. Society can see diminishing returns if technology spreads without oversight, accessibility, or trust. A breakpoint is a hypothesized threshold where more AI stops helping proportionally and new harms appear. The study's benefit burden ledger exists to price costs alongside wellness proxies, not to declare a breakpoint in advance. Can always regress. So why run it? Waiting years for perfect longitudinal data would delay learning. Scenario modeling lets us stress test assumptions now while labeling them as assumptions. We use a sample of 1,000 modeled adults we generated from published summary statistics, age, BMI, activity, and related measures, not real participant records, not production user data. We have two different modes. Forecast mode uses fast formulas for 90 days, 10 years, and a lifetime. It powers the detailed results on the research page. Simulate mode steps through 90 days, one day at a time with random daily noise on AI usage, mood, and nutrition. A methods check. Those improver stats appear on the home research page summary. Same cohort, different math. Always label which. What does the site measure? Nutrition, lifestyle, mood, alignment proxies, and a population risk outlook. Same family of method as the in-app timeline education outlook, and a USD benefit burden ledger in US dollars. Wellness proxies versus AI, API, hosting, and planetary costs. Say it plainly, this is not a scorecard for the whole app. Limitations. Synthetic data. Assumed adherence lift under with AI. Educational systems modeling only, not medical advice or exact prediction. Validate with real longitudinal data before casual conclusion. USD figures or scenario assumptions, not audited financial claims. Publishing that list is part of budgeting for known error, what we refuse to hide. Where the budget is stronger versus thinner, the trade-off ledger applies plus or minus 50% sensitivity on environmental cost terms, shown for the 10-year with AI lens. So net benefits there should be read as a range, not a magic point. That sensitivity does not equally stress test the 90-day plus $426 headline for the adherence lift assumption behind 100% improvers. Unknown unknowns, new harms, language equity gaps, live hallucination rates. These are the unknown unknowns. Remain open research. They are not closed by this run. The confidence, it's useful for planning and risk spotting, not high confidence for clinical or policy mandates. Aligns with responsible AI risk management, map risks, measure, manage, and avoid overclaiming. If you open the public URL to verify, you may need to sign in or continue as a guest. The numbers live in the product. Here's what the product currently shows, starting with the home research impact summary. Remember, you can go look at the product. Remember, narrow proxies on synthetic people, not proof that every scan and find it feature works in the real world. 90-day simulation under the stated assumptions with AI, 100% improvers. Without AI, about 31% improvers and about 44% decliners. On the research page, an improver means the composite of nutrition, lifestyle, mood alignment rose by more than 0.02% over the window scenario math on synthetic profiles, not that this person got clinically healthier. Treat 100% improvers as an assumption-driven scenario output. For the population output, the 90-day forecast with AI versus without AI, and the same 1,000 person synthetic cohort, the model estimates about zero point 0.4 plus on a modeled healthy life years proxy and about negative 4.9 percentage points on a model type 2 diabetes risk proxy. The site's own framing, educational systems modeling, not medical advice, not exact prediction, not a clinical prognosis for any individual. For the benefit burden for the 90-day forecast, modeled incremental net benefits of about positive 426% dollars per person after API and environmental costs. Again, a scenario assumption, not an audited financial claim. The full research page adds longer 10-year and lifetime forecast tables under the same assumptions, so you can take a look at that 10-year and lifetime forecast. The methods copy warns that simpler forecast math can look clean but extreme at long horizons. So treat those tables as more uncertain, not stronger proof. What does this not mean? It does not prove real users will improve. It does not evaluate nature, fire, meds, modules, communities, or professional use. The with AI scenario assumes a positive adherence effect. You have to validate with real data before drawing casual conclusions. Unexpected cautionary reading, a model that assumes benefit will usually find benefit. So the scientific value isn't a magic number, it's a transparent machinery. Assumptions, formulas, and modes written down so others can challenge them. Plus the forecast versus simulate methods check and pricing environmental costs alongside wellness proxies. Agent safety eval harness results in the repo are a separate engineering signal, not clinical outcomes. What about bias? AI systems can reflect bias in training data, language performance, demographics, culture, and accessibility. If a wellness tool works better in one language or for one age group, average improvement can hide harm. So it's important. The research results page does not publish demographic stratified outcome tables for the stimulation. What follows is product risk awareness, not a finding from synthetic cohort run. Mitigations this project aims for in terms of bias: multilingual UI, screen reader oriented labels and roles, contrast and keyboard considerations aligned with targets, consent before AI photo voice chat, human readable disclaimers, citation backed educational answers where integrated, eval cases for safety refusals, and continuous monitoring plans. U.S. disability rights laws under the ADA are complementary along with the WCAG. The WCAG is a technical standard many organizations use to pursue accessible digital experiences. Some things are still unsolved. Equal model quality across all languages and accents. Full assistance coverage, including Braille hardware workflows. Eliminating all cultural blind spots. Improving equity in real-world outcomes. Where a stronger claim can't be verified, no authoritative source was found for this claim that the product is fully bias-free because no serious system is. Technology can improve life up to a point, and then create regressions if deployed carelessly. Automation dependency, weaker critical checking of answers, misinformation, or accessibility regressions when redesigns break assistive tech. This project tries to push against that by keeping educational framing, requiring AI consent, showing disclaimers, preferring sourced health topics over free inventions, rate limiting and securing APIs, and treating accessibility as a release concern, not an afterthought. Perfect prevention isn't claimed. Oh, finally. Of course, AI comes with some risks. We already talked about bias. Bias causes include skewed data and uneven evaluation. Impacts include unequal access and trust. Mitigation follows risk frameworks like the NIST AI RMF and bias guidance. Residual risk remains. There's also hallucination. Generative models can produce fluent falsehoods. They matter most when users might treat education as medical orders. Mitigations, retrieval citations, refusal guardrails, human verification, and never replacing clinicians. Confidence scoring helps when calibrated, not as a magic truth meter. Another risk is the environment. Training and inference consume energy. High frequency consumer AI can add up. Practical minimization. Cache lookups, prefer lighter compute paths when a heavier AI call isn't needed. Measure per feature cost proxies and avoid unnecessary calls. Plagiarism is another risk. Use public databases with attribution and non-endorsement where required. Keep original product copy. Don't present model text as peer-reviewed science. What about if AI steals our jobs? Like prior general purpose technologies, industrial machinery, electricity, PCs, the internet, smartphones, AI will displace some tasks, create others, and distribute gains unevenly in the short run. Avoid doom or utopia. Plan for reskilling, accessibility of tools, and human oversight in health adjacent education. Last one, security. Authenticate users, authorize data access, encrypt and translate, protect secrets, rate limit AI endpoints, and watch for prompt injection and abuse. Scan and Find It is an attempt to make general wellness support more reachable across body, environment, safety, and community. The research page is a different artifact, a flashlight on a scenario assumptions for a few wellness proxies and costs, not a final exam on the whole product. We budget for some known error, stated assumptions, limited costs, sensitivity, disclaimers, human judgment, and the call to validate with real longitudinal data. We do not pretend that closes the unknown. If we keep measuring, inviting critique, and reducing uncertainty step by step, we can produce and build tools that help people without letting a tidy chart speak louder than the method behind it. Not medical advice, not FDA-approved, educational system modeling. View results at scanandfindit.com/research.